So domain 4 is social vulnerability. That is to assess factors such as social isolation, economic insecurity, caregiver stress, and potential mistreatment or elder abuse, and incorporate the findings into the care or discharge planning for the patient. Currently, it is being done through a variety of vulnerability and social determinant health screens, which can be seen on the screen as a few examples.
Sorry, the one other point I meant to add is that initially was started by the John A. Hartford Foundation and the Institute for Healthcare Improvement. So they've been the ones to drive this. But I think initially, I think it's nearly 5,000 sites of care now that are deploying it.
Thank you.
I have a question about social vulnerability screening. This is everyone coming into hospital to get SBOA screening, right?
They do, as a part of the intake on admission.
So when older adult comes in, does it like actually automatically ask different questions or add questions?
That's a great question, and my understanding is, I will.
Yeah. Hi, Ben Lawton. I'm the Chief Nursing Informatics Officer. All patients who are admitted to the hospital have a standard screening that is done by inpatient nurses that has a variety of components to it. One of those components is the social determinants of health, and they ask specific questions, including some social vulnerability questions, and it's part of expected standard documentation for every patient that's admitted. We also address social vulnerability in the ambulatory space through a variety of more ambulatory-specific screening forms.
All right, Ben. Oh, go ahead. Did you have a follow-up?
Well, just to make sure what you meant is that social vulnerability questions, screening questions, is the right age for the
I'm sorry, can you repeat that?
So my question was, your social vulnerability or SBOH questions, screening questions, actually differ by age group.
Our social vulnerability questions are standard and asked for all patients across the system, and they include specific questions about economic insecurity and caregiver stress.
Yeah. So it's stratified by age, the standard question stratified by age. Right. And are you seeing anything in particular that is more significant in the older adult population in terms of vulnerability? Or you can come back with that if you don't know offhand.
Yeah, so right now we are coming up, we have a leadership team, and we are trying to come up with a plan. So this is what is already in, so the data will be collected, and then we are going to implement more changes moving forward, what we think will help our patients the most.
Okay. Director Sorrell, I think you have a question or comment.
Yes, thank you, Chair. In regarding pain assessment, are there additional pain assessment questions as part of this determination on admission to make sure that patients, particularly those persons of color or older patients, are getting adequate pain management care while addressing the potential risk for opioid or risk for addiction, but that they're getting adequate pain management? Because that's a noted issue as well for that older generation of under treatment of pain.
So thank you for the question. So pain assessment is part of the clinical evaluation when patients are admitted. As per my understanding, there is, so the nursing intake, they are going to ask the questions related to pain standardized to all the questions. I do not think at this time we have any specific questions in our patient population who are 65 or older, specifically for the pain.
There may be, I think Director Sorrell, maybe one of the things that your question sparks is there a connection we can make between domain 3 and the frailty screening tools in the context of pain? So those that may be at higher risk as a result, of their pain score. or vice versa. I'm not sure. Is that why
Excellent. Right. Yes,
Yeah.
exactly. And that unfortunately with untreated pain, that may lead to additional disability, uh, lack of mobility, and sadly, worsening outcomes.
That's a great point. Thank you. If you go to the previous slide, everything in our opinion, everything contributes to the frailty, and all of these factors are very important to address, considering patients' frailty, the medication management, mobility, what matters to them, everything contributes to the frailty. So it is a very, I would say and like frailty is very important to address in our patients, and we will collect the data and come up with a plan moving forward.
Is there a score or criteria? I assume when you do an assessment, you look at certain criteria, and based upon some kind of score, you assess the level of agility.
To assess the level of what more, based on the data, what are the more, what more needs to be done to appropriately care for the patients and then to plan for a safe discharge for the patient. So that does, the data does help us with the discharge planning for the patient, what services need to be involved.
And that's done for all patients.
It is done for all our patients. First, can we
go ahead.
move to the next slide? Slide, next one, please. Oh, yeah. So as a part of the initiative, we have also, there's an age-friendly care leadership, which is interprofessional committee to prioritize age-friendly measures and support staff education and update leadership. Currently, our leadership team consists of following: executive sponsors, Dr. Mahapatra and Dr. Akre; lead champions, myself and Dr. Dixon; collaborating lead partners from DGIM, Dr. Nancy Jacobs; from ER, Dr. Lewis; hospitalist, Dr. Sanati; and pulmonary group, Dr. Talamat. Now, tools are being built within the electronic health record to allow caregiver and leadership focus on the age-friendly care. As you can see on the screen, that is a work list which will be available to all the partners who are caring for the patient, so that we can take appropriate measures. Next slide.
Okay. Pat Merriweather on our virtual.
Yes, I'm looking at this for the age-friendly care leadership, and I don't see any patients or families involved or caregivers. And that sort of ties into the other measures that are going on, where there is not a requirement, but an urging to include patients and families in there. And I think it would be worthwhile to hear from people. I think there's a major difference between 65 and 85, and it would be helpful to have, there is variation in services and support that's needed. And I would also suggest that many are looking before 65, because if they have a condition diagnosed at age 65, there could have been preventive services before that. So again, I just think that we're missing an opportunity there.
Thank you, Pat. Any comments in response?
Thank you
Okay.
so much. That's a great suggestion. We'll definitely consider that.
Yeah. And I think the other thing, again, this is, actually this bundle is good for all adult patients in the system. So, and particularly for our communities that we serve, there's potential for accelerated aging, right? So you may, these issues that show up for older adults may show up earlier. So there may be be an opportunity to kind of use this as an opportunity to elevate, you know, continue to elevate the great work that the health system does. Okay, go ahead. Yeah.
The next step, the path forward. So currently, the process is to complete the EHR reporting enhancements to drive clinician engagement and compliance. Project kickoff is by end of the March, where the data will be collected over the next 6 months, and data will be utilized to make further improvements. To streamline workflows to make compliance easy and efficient, reinforce priorities through clear communication and leadership emphasis. Both will be ongoing processes over the next year.
Great, thank you. Any other comments, questions from the directors or online or virtually? Okay. Well, thank you for sharing this, and we'll look forward to updates in future meetings. Thank you, Dr. Lawton, Dr. Thirlwell. Okay, we'll go to our report on upcoming changes to the committee format. So that's reviewed by Dr. McCormick and Raji Thomas. And I know that Dr. McCormick and Raji and Eric and I have talked about the approach here to enhance some of the opportunities for discussion and visibility to a broader set of topics. So thank you for this.
Good morning, directors.
Good morning.
Good morning.
Both Raji and I'd like to present or propose some changes to the QPS quality reporting structure that we currently have. Reasons for action, why would we want to do this? Well, underneath a lot of this, 2027 CMS will require structural safety measures. Those structural safety measures include a development of a learning environment within your facility, which effectively means how do we, as those running the hospital's operations, relate to and learn from those on the front line to help solve the issues that are really under the domain of quality and safety and to keep our patients safe. And part of that reporting structure includes the need to have a structure that reports all the way up to yourselves, very well demarcated in your documents and in your process and procedures. That's one of the reasons the bylaws are being addressed as well, because every part of the bylaws requires an organizational and structural manual for the medical staff. And how the medical staff committees report up to the board is one of those things that will be specifically called out in that bylaws review. But moving forward, what are the other reasons? And all of this is related to developing that learning environment for our facilities. So increased awareness and the real-time efforts of the frontline staff is very important. So how are we engaging our front lines and helping us solve problems is something that we really want to bring forward to the board on a more recurrent basis. A more unified look at our meetings, our report outs, what it looks like, standardized and structured data that will be presented at a set cadence. Excuse me. Presentation of a comprehensive picture of the state of the quality, which will include all of our venues, meaning Stroger, Provident, but also includes CIRMAC, CCDPH, as well as County Care and ACHN, which are things that we aren't commonly reporting out on a iterative or a good cadence. So we're going to start including those in the cadence. And most importantly, the ability to highlight the commitment that we have to ongoing improvement efforts in the facility, which we think are, I wouldn't say more important, but are not really highlighted well. Currently, we're showing a lot of dashboards with a lot of data on a monthly basis. A lot of that data doesn't change very frequently, and so we're spending a lot of time looking at the same data. What we'd like to do is have that data presented to you in written format on a quarterly basis, showing that all of those metrics that we are held accountable to, but during our monthly meetings, we'd like to highlight the improvement efforts behind all of those data points and get you more engaged in actually what we're doing with our frontline staff to improve. And there's a lot of work behind this. There's a lot of structural changes that have to occur. So it is a work in progress, but that's where we're going to. So what are the major changes? The next slide, please. So restructuring the quality reporting improvements under the system quality with medical staff oversight and the incorporation of nursing education. So I kind of spoke to this at a previous meeting, but basically we have a lot of siloed activity going on in our medical staff, in our nursing, and in our quality. We have a system quality now, and we're moving towards bringing everything and integrating everything together. So effectively de-siloing our quality and process improvement work and trying to emphasize the improvements in a standardized way. All sites will be bringing their dashboards. So as I mentioned, we'll be bringing all sites, including CCDPH, ACHN, CIRMAC, et cetera. We'll be changing, changing the cadence of meetings. We really would like to, on a quarterly basis, have one QPS meeting dedicated to quality and safety. The next would be dedicated to patient experience, and then the next would be dedicated and a scheduled closed session for peer review as well as regulatory. Of course, we'll continue to do the work for the medical staff with regards to approving of credentials, et cetera, because that's an ongoing need to have, so we don't have a latent period for privileging. So that's an ongoing kind of a working part of the agenda, but we want to have focus on our agenda on a quarterly basis. So we don't have to continue to look at the same OpEx dashboard with the same data. We want to be able to have that OpEx dashboard in the background for your viewing, but we'll pull out those things that we're emphasizing and de-emphasizing, but emphasizing with process improvement work. And we'd like to highlight that for you on a set cadence.
Just a quick question about dashboard. Are these dashboards actual dashboard online so people can access, or is it like Excel file that you have?
So each site would have their own quality safety comprehensive dashboard. That would look slightly different than what you've been seeing for the past few years. We've been mostly focusing on the areas that our PI teams have been working on for the past couple of years, but what you would see is a more comprehensive picture. Like, for sepsis, I know we usually talk about the bundle compliance here, but you would get to see the overall sepsis performance. That's an example. So we are trying to mimic what the report we get back from VCN that shows our numbers under each of the 5 domains. So what you would see would be a lot more metrics than you see now, but it would be specific to each site. And we are hoping that there would be more discussion on those metrics rather than just presenting on the PI work that's happening. We also feel like we are rushing through these dashboards every month, and there should be more discussion. And we are trialing that this month, actually. We brought in age-friendly groups. We have sepsis team coming here because that's what the board wanted to hear about last month. So we are trialing what we are proposing here, starting with this month.
And as I say, it's a work in progress, but I think throughout this year, you'll see significant changes in this agenda, in this meeting, and hopefully a lot more back and forth discussion about what we're actually doing to improve our quality metrics and our safety metrics, and what the frontline staff have actually been engaged in and what they've come up with to assist us in keeping our patients safe. And I think that's the goal of our meeting, is to have that exchange and to make sure that you're informed of exactly what's going on. One thing that, again, I think will be different is a scheduled closed session. So with the bylaws review, we're formalizing a more formalized peer review process that assures due process for all clinicians, but also assures us that we can look at peer review events that may be within peer review, and look for opportunities for improvement to take out of those and look at our processes and less about the people. But when you do have to look at the people, you need a formal setting and a fairly strict way of doing so to make sure that everyone is treated the same. And that's what the peer review process will be designed to do within our bylaws. that in order to continue with the legal peer protection that's afforded by the state and the federal law, we would need to have a closed session for peer review, and those things would be discussed. There's ongoing things that they do in peer review, such as FPPE and OPPE. Those things are more done on that would be kind of a set part of the agenda, just the overview. But then specific cases where there's maybe provider concerns or where there's provider excellent care provided, I think it's important that we spotlight that to the board as well, because ultimately CMS requires that you're the overseer of the quality and safety of the organization. So that'll again be in a scheduled closed session on the same set cadence. So like every third month there'll be a closed session.
Can I add something?
Yeah.
So for example, I know the board has asked questions around our mortality review processing. That is really for a closed session discussion, right? Not for an open platform. So those are the type of topics we are hoping we would be able to bring to those closed sessions and really have a conversation around.
I think there, any other questions on this slide? I think you have one more or a few more.
I think I've covered them in general.
Okay.
We've already covered that, and the next slide is just an example of the cadence, which is kind of a moving target right now, but you get the idea that we would dedicate a session to patient experience, and then we would not talk about quality and safety that month. Then next month we would talk about quality and safety, and we'd be able to have a deeper dive and a conversation. That's the last slide, but I think I've covered them all.
Yep. So to ask the directors here online if there are any suggestions, questions, comments to this, what's your reaction? Does it make sense? Anything you would want to see different?
I actually do like Jason.
I agree.
That makes sense. It also allows us to vary if there's additional questions that we have too, that we can get clarification on it as well.
I think it's great to move in this direction, and I think the patient experience, I'm hoping that patients and families are involved in that as well, because I think that's really critical. But I also wonder, how are you going to then handle, because there's reporting within the hospital about errors or near misses. How will you be handling that during this time?
So our existing internal structures will continue to perform the same way as it currently does, Ms. Meriwether.
Okay.
So we have patient safety committee that meets on a weekly basis. We have oversight committee for physician-related or system-related concerns that we currently conduct. Over time, that will transition over to peer review committee. However, the current structures for reviewing safety events will not go away, but the way we bring that information to the board would look slightly different, in a more structured way that would allow for more discussion.
Okay, great. I just wanted to make sure that because the timing on those errors and near misses are critical. Thank you.
Yeah, and Ms. Meriwether, actually we are adding additional structures to support our reviews of safety events and quality metrics. In the past, as you know, we had site-level committees that reviewed these metrics, but one of the major changes that Dr. McCormick is introducing is taking those committees to one level down. So we are in the process of standing department-level committees that will be reviewing their specific data and would be taking ownership over addressing any concerning trends. So by next year, we are hoping that there would be one more layer introduced in that committee structure where each of our clinics and units would have their own dashboards and, committee structures. So it would also support what nursing has been doing on their end with shared governance. So it's all coming together. There's a lot of great work happening right now. The team here, quality team, is in the process of working with each site and the departments under those sites to stand up those supporting committees and councils. I want to answer one of your questions from before, for age-friendly as well as something you just asked. So we do have a PFAC, Patient and Family Advisory Committee, that Link's team, leads. I think she's presenting next month on patient experience, and we are happy to bring to this board additional details on how we engage patients and families. And definitely your feedback on age-friendly measures, engaging families and patients, we will definitely work with that group to see how we can incorporate, those expectations, CMS expectations there.
Yeah, it'd
Okay,
be good to hear about that connection,
yes.
with the PPAC with age-friendly.
And I'll just close on one comment. I just want to make sure and assure you all that the medical staff's primary responsibility is oversight of the quality and safety of the activities that go on in this hospital. This is why they are over credentialing. This is why they are over peer review. This is why they're have the oversight, which has been given to them by the county. It's very important to understand there's no intention of removing that at all. What we are going to do is pair the medical staff with process improvement professionals along with our quality team and our nursing team all together on our councils and our department councils, and it'll all be led, again, getting back to the bylaws, it's all going to be directed through the restructuring of the bylaws through the medical departments. So there will be no detachment at all of the departments, department chairs, et cetera. I know change is difficult. There's a lot of moving parts here, but the ultimate end product, the ideal state, will result in a much more, a culture of sharing of our improvement processes, and hopefully improve sustainability of all of our improvements by engaging the frontline staff in continuous improvement and engaging us in continual learning. So,
Yeah, I think the sustainability piece is important. Thank you for mentioning that. That's, the improvements that you deploy want to continue, that they are enduring, across the system. And then, Director Harrington, do you have a question, comment?
Well, it was a comment more than anything else. I just want to thank you and applaud you for actually organizing this in a manner that's probably more digestible, because we have a very large system and we look at things from a system perspective. But what you've done is you've broken things down. You have 8 categories that you're going to be reviewing over the course of the year, but some will get special attention. So that means we'll probably catch some things that we wouldn't catch if we're always just looking at the big picture. This allows us to drill down in a way that how you presented before will allow us to maybe capture things we wouldn't capture otherwise. So.
Well, thank you. I appreciate that. And Raji's the one who's organized it.
We will continue to tweak based on your feedback. So we request your patience as we trial and error this framework, but I'm sure we will get to a perfect place.
It's like drinking from a glass instead of a pitcher.
Yeah. And it doesn't change our governance responsibility either, right? This is just, it actually allows us to better enhance, our responsibility in governance and support the team and the great work that they do. So, thank you.
Thank you
So much,
Yes.
and thank you, Dr. McCormick and Raji, for the work on this, and thank you to Dr. Gurwal and Dr. Lawton on age-friendly and the leadership there. We'll look forward to the work here. The other thing I would say is just would have consistently the quality strategy visible maybe at the next meeting, just so we can refresh the committee on that, because this all maps to that quality strategy as well. So thank you. All right, we will go to our regulatory update, reviewed by Joseph Capena, Director of Quality and Regulatory. Good morning.
Morning.
Good morning.
We provide regulatory updates, and this is status of recent visits and upcoming surveys. Unannounced Joint Commission visit at Stroger for a patient complaint took place back on Tuesday, February 17th. One day or half a day visit, with one surveyor. We were cited with the deficiency. We did receive a report, and we're currently working on responses, so that's a work in progress currently. Unannounced IDPH investigations focused on emergency services at Stroger. This took place over 2 days in December, the 23rd and 24th, just before the holidays. We found that we were in substantial compliance, so that's great news. IDPH outpatient dialysis. This is a recertification due at Stroger, and it's been expected at any time, and we are still waiting on that. Cancer registry team for Stroger. We have a virtual site visit coming up next month, which is going to be on Tuesday, April 21st. And IDPH EMS Resource Hospital Site Survey, also at Stroger, we're scheduled for Thursday, October 22nd. Next slide, please. Continuing, we have the National Commission on Correctional Health Care, or NCCHC, at CERMAC. This is for mental health accreditation. We're applying for accreditation with the goal of a 2026 survey. We also have, through NCCHC, at CERMAC, jail accreditation, and this is to occur it won't occur until the second quarter or later. We have IDPH perinatal redesignation at Stroger. This is scheduled for Thursday, November 19th. And lastly, we have the Joint Commission Triennial Survey at Providence. The previous visit was over 4 days in December of 2023. It's unannounced, but we're anticipating they may come September to November with the plan of being prepared by the summer. Next slide, please. So this is a kind of a snapshot of some findings during with our Provident Triennial Prep, and I've just listed here on the right-hand side the top 6, and this is found through multidisciplinary team doing observations. So the top 6 are expired products, which we're able to take care of and pull on the spot, logs missing checks, the environmental dusty sprinkler heads, expired hand gel, again, that comes from areas maybe have less frequency, they do have expiration dates, missing preventive maintenance on equipment, and then lastly, dust on ceiling vents. And these, again, are just the top 6. Next slide, please. As far as Provident Triennial Prep, so I wanted to kind of spell out here what's being done currently. So we have a continued weekly multidisciplinary round, which I showed some of the observations earlier, that continues every Tuesday. We did provide a self-assessment for staff, a weekly self-assessment. I got some feedback the other day that some staff are using these on a daily basis, which is great. Kind of a checklist. We are running tracers, tracing patients through levels of care, where we're looking at both a chart review and staff practice as far as questions being asked, how to properly answer questions. And we're doing a little bit of a deeper dive in that, doing more focuses on pain management, suicide ideation, and a number of other areas. As far as focal points, we are planning in the month of May a mock survey working with an outside consulting company. We are doing some focus tracers. Most recently, did one in sterile processing, looking at scopes. And just earlier this week, we did a round through the pre-op, day surgery, and the PACU areas. I'm working on the early stages of what's a survey process guide, which will be a booklet for staff as far as information and reference. I'm updating a hospital document list, which is a requirement from Joint Commission, 60 documents that they have on site when they walk through the door that they can quickly review during the entry, and that should be done within the next 2 weeks. And then a couple other things down here at the bottom. This is older information. We did launch earlier this week a quick tips, which is a weekly alert on regulatory things to give staff some information, obviously get them thinking about the survey, and rolling out next week. Plan is on Tuesday the 24th. I think something I call red folders, which is literally a red folder, and it's a color choice that stands out, and it's a kind of a go-to guide for the units, loaded with some information. So when the surveyors walk through the door, roughly around 8 o'clock in the morning, especially day 1, they've got about 2.5 hours between when they present, set up their laptops, do a meet and greet, the opening presentation, where units can then go to this folder and say, okay, what are some of the things we can do in that time window before they start running tracers to prepare? And obviously they can use those in days 2 and 2+ as well, because there is a window of opportunity between when surveyors present and when they actually run the tracers in the units. So that'll roll out next week, and that's what I have right now. Happy to answer any questions.
Thank you. Any questions, comments? Virtually? Nope. Okay, thank you for all the work on this.
Thank you.
And the report. Our quarterly grievance patient experience report will be reviewed by Lynn Bank at a future meeting. Our Chief Experience Officer, thank you for the continued work in this area, and we'll look forward to report the next meeting. The committee will now go into closed meeting, so actions not expected to be taken in open session after discussion in closed session. So motion to go into closed meeting pursuant to the following exceptions to the Open Meetings Act, ILCS 122, 111, 12, 17. Need a roll call vote.
Roll call vote on the motion to go into closed session. Aye or nay? Director Kim? Director Harrington?
Aye.
Chair Bott?
Aye.
And I believe Director Sorrell may have disconnected. So you have 3 yeas and 0 nays. Sorry.
Thank you. We'll go into closed meeting, so we'll need a few minutes here.